Oncolytic immunotherapies have shown great potential in the treatment of advanced melanoma. Melanoma is a unique tumor for this approach for two reasons. One being that there are patients who present with superficial tumors that can be injected, and so the medication can be administered intratumorally. These patients have both palpable lymph nodes as well as in-transit or cutaneous lesions, which are very easy to inject, sometimes multiple times. In addition, melanoma is a very immune-responsive tumor type, meaning that therapies which help induce an immune response can be quite effective in treating this disease. So for nearly a decade now, existing oncolytic therapies, such as the FDA-approved therapy T-VEC or Talimogene laherparepvec, has been already been used in treatment of this disease. Now, when this approach first started being used to treat melanoma, there were a couple things to be noted. The initial Phase III registrational OPTiM style study looked at the use of T-VEC, and the comparison was GM-CSF. And so when this therapy was injected into superficial lesions, it was shown to lead to durable responses and certainly clinical benefit. But really, the patients who benefited the most had sort of limited disease. And what we did not see was a great deal of abscopal effect or responses in non-injected lesions when using T-VEC. And so while it was recognized that this was an effective therapy, there was an understanding that it also had some limitations. And then subsequently, T-VEC has been studied in combination with other systemic therapies, including PD-1 and CTLA-4 inhibiting drugs. And this has also been demonstrated to show some degree of success, but unfortunately probably not as great as what we had hoped for. In some Phase II studies, there were certainly patients who had good responses, but results have been a little bit disappointing in Phase III studies. So T-VEC has not really kind of become, I'd say, a standard approach across the board. Building on this strategy, though, this novel oncolytic virus, RP1, is now being in development. And so to briefly describe the differences between RP1 and T-VEC, there are two things to point out. So T-VEC was genetically modified to become less virulent and also to express GM-CSF. And RP1, in addition to those modifications, also was engineered to express a fusogenic glycoprotein, GALV, which allows this oncolytic virus to further induce immunogenic cell death. Second key difference with the use of RP1 is that this drug, in addition to being injected to superficial tumors, is also being studied as a therapy that can be injected into deep visceral tumors as well. So when we recently presented data from the IGNITE study, this seemed to demonstrate improved clinical efficacy. And so hopefully this will lead the way to additional oncolytic viruses being studied and additional genetic modifications as well to maybe even newer viruses as well.